Over the next 10 minutes, I'll share with you something on NIRS, the near-infrared spectroscopy. What exactly is NIRS? Near-infrared spectroscopy, it identifies the composition of the plaque, it scans the blood vessel, it looks for the lipids inside the blood vessels, and it gives us a yellow image on the monitor. That's how the display would look like. You could see the chemogram down there. In the chemogram, you could see red areas as well as yellow areas. Yellow areas, it's primarily the lipids inside the blood vessel. Well, what do we look for on the monitor? You look for these yellow areas. When you see a lot of yellow areas on the monitor, it makes us understand that this particular patient has got multiple areas of vulnerable plaques, and this particular patient is a vulnerable patient. Now, it also quantifies the lipids inside the blood vessel. You call it as the lipid core burden index, that's LCBI. You could have two parameters monitored there. You have two values there, the blue value, the yellow value. The blue one is the LCBA of the entire vessel that's been scanned. The yellow value gives the maximum amount of lipids at a particular place. So looking at this LCBA max, you get to know where exactly you have the significant amount of lipids inside the blood vessel, where exactly you have the vulnerable plaque inside the blood vessel. And at this point of time, we do have enough of the data that makes us understand that when you have an LCBA max of more than 400, this particular patients, they correlate with a very high incidence of future MIS. That is, over the next 2 years, they are likely to have 4 times more events when you compare with somebody who's got a LCBA max of less than 400. Well, what exactly is NIRS and IVUS technology? It's a dual imaging technology wherein you have a single catheter which incorporates both the transducers. On one side of the screen, on the left side, you could see the IVUS images. On the right side, you could see the NIRS images. How exactly is this accomplished? In the tip of the imaging catheter, you have two transducers. One, it's the IVUS catheter. It looks at the structure of the vessel, and on the other side, you have a couple of mirrors that scans the spectroscoping, that gets the spectroscopic images, so that you have on the screen, you have on the left side, you have the IVUS images, and you have on the right side the NIRS images. And again, when you look at the NIRS images, you could see here that this actually correlates with the longitudinal pullback of the IVUS images, so that you can clearly understand where exactly in the vessel you have vulnerable plaques, and you could probably extend the stent proximally or distally so that you can cover these vulnerable plaques also. Now, what is the clinical usefulness of NIRS IVUS in our regular practice? Now, you could identify procedural risk during PCA with the help of NIRS. This was an elderly patient, 83 years old, who presented with recurrent rest angina. You could see that he's got a very critical stenosis in the proximal left antidescending artery. When we look at the IVUS NIRS images, the IVUS shows us that there is a significant lipid pool. You could see that it's an attenuated plaque over there. When you look at the NIRS images, you could see that the LCBA max is almost 722. When you have a huge LCBA max of more than 500, it would correlate with a distal slow flow during the procedure, so that you can be prepared to manage the slow flow in this particular patient. So when we went ahead with stent implantation, despite not doing a post dilatation, just after stent implantation, you could see that there was a significant slow flow inside this particular vessel, and we prepared to manage that slow flow, managed with intercoronary vasodilators. You could see that that's the final result. Still, you could see that the diagonal is not really flowing well. So just to highlight the fact that when you have a huge amount of lipid pool inside the vessel, this correlates with slow flow inside the blood vessel during the intervention. This is a very similar lesion in a lady in a different person. You could see here that in the IVUS, you could see that there is significant amount of lipids. You could also see that it's an attenuated plaque. On the lower frame, you could see that the NIRS imaging shows us that the LCBA max is significantly less than 400, which means that the lipid pool is not huge. So then the chance of slow flow is less likely. Went ahead with stent implantation, post dilatation. You could see that there was no significant slow flow during the procedure. So NIRS gives us an idea whether you would have a high risk procedure. Are you likely to have a slow flow during the event? If you have a huge LCBA that's more than 500 or so, then you need to be prepared to manage the slow flow during the interventions. Now, NIRS also identifies high risk vein grafts. This was a patient who had undergone a bypass surgery almost 10 years ago, now an acute coronary syndrome. You could see that in the distal right coronary artery, there is a critical stenosis there. We evaluated with NIRS IVUS system. In the IVUS, you could see that there is no degenerated tissue over there. It's more of a fibrotic plaque. In evaluating the NIRS, we made out that the LCBA max was less than 400. You could see that it's 233. So we understood that it was not a very degenerated plaque over there in the distal vein graft. So we didn't want to go in for a distal protection device. We went ahead straight away, direct stenting, post dilatation, and You could see that despite not having a distal protection device, the flow is good in this particular vessel. There's another patient who had undergone bypass surgery almost 20 years prior, 10 years prior, angioplasty to the vein graft, now comes with recurrent rest engine. You could see that there is no flow inside that particular vein graft. The distal vessel is not seen at all, and you could see a very critical stenosis over there that was actually inside the stented segment. That particular critical stenosis was there. When we evaluated NIRS IVUS, you could see that the vessel is almost 4.5 millimeter in size. The stent implanted there was 2.75, and you could also see on the NIRS system that the LCBA was more than 500. It was 611, which makes us understand that it's likely to have a distal embolization in this particular patient. So we went ahead with a distal protection device in this particular patient, and you could see in the final image that all the vessels distally is very clearly seen. The right coronary artery, the OM branch, everything is well filled up following the intervention. So NIRS makes us understand that when you have a degenerated graft, when you have a huge amount of lipid pool inside the vessel, you need to have a distal protection device, and be careful while managing this particular patient compared to someone who's got a very low level of lipids inside the vessel. Now again, you could also identify the low risk subset of patients during a coronary intervention. This is a patient who had a primary angioplasty to the right coronary artery. You could see on the left system, left main bifurcation has got a very an intermediate stenosis and ulcerated plaque in the left main bifurcation. We're not sure what exactly to be done for this, whether we should be stenting this particular lesion or not. We evaluated with NIRS IVUS. On IVUS, you could see that it's an ulcerated plaque. However, the luminal area there is more than 10 millimeters square. So a huge luminal area with an ulcerated flap over there. We're not very sure whether to stent it or not. When you looked at the NIRS images, you could see that the LCBA is less than 400, which makes us understand that there is no huge lipid pool over there. So a good luminal area, less of lipids over there, we decided that we'll manage him medically in this particular patient. Now we could also identify the stent length while managing the patients for interventions. This is a patient who had an acute coronary syndrome. You could see that there is a very critical stenosis in the distal left antidescending artery. However, in the proximal antidescending artery, you could see that there is an intermediate stenosis over there. Is this not stenotic plaque dangerous? We evaluated that particular area with NIRS IVUS. You could see 3 images over there. In the first image, you could see that the plaque burden there is almost 70%. In the second image, you could see that it's more of lipid pool on IVUS. It's more of an attenuated plaque. And in the third image, you could see that there is a huge LCBA. The lipid is huge. It's more than 600, which makes us understand that this is a vulnerable place. This is likely to create problems for this particular patient in future. So we decided that in addition to stenting the distal critical lesion, we'll extend the stent more proximally. So we had a couple of stents implanted there, and we were able to achieve good results. Now we could also, while doing bifurcation intervention, you could also understand which vessel has to be given huge amount of importance. This was a patient who presented with an infused myocardial infarction. You could see that the right coronary artery is totally occluded. Once we opened up the vessel, you could see that the vessel is entirely diffusely diseased. The PLV branch is diffusely diseased. The PDA branch is diffusely diseased. The proximal right coronary artery has got an intermediate stenosis. What do we do for this particular patient? We didn't want to deploy multiple stents in this particular patient. We evaluated all the vessels. You could see distally that in the PLV, the LCBA is more than 400. In the PDA, the LCBA is significantly less, and in the proximal right coronary artery, the LCBA is quite huge. So ultimately, we decided that probably we should leave that PDA branch because there is no significant amount of lipids in that vessel. So we decided that we'll do a depth to the drug-eluting balloon to the PDA. Then we went ahead with stent implantation to the proximal right coronary artery and the PLV branch. So a couple of stents and a depth to the PDA, and that was the final result that we could achieve in this particular patient. Well, you could also identify the likelihood of developing slow flow during intervention in acute myocardial infarction. Somebody who gets admitted with acute myocardial infarction, if you evaluate NIRS, if you have a huge amount of LCBA, then you are likely to know that this particular patient is likely to have more and more of slow flow during the intervention. You could see that this is an infused myocardial infarction. LCBA was huge, and following stent implantation itself, you could see that the slow flow is developed. We had to give a lot of intracoronary vasodilators and settle down with that. A very similar lesion, another patient, infused myocardial infarction, you could see that the LCBA is significantly less. So we were sure that this particular patient, the chance of distal embolization is going to be significantly less. Went ahead with stent implantation, post-dilatation, and you can see that the flow is quite good in this particular patient. Now you could also assess the adequacy of the results while doing interventions with the help of NIRS. See that this was a patient with acute coronary syndrome, a large PDA, 2.75 millimeter PDA. Stent implantation to the PDA was done. Following the stent implantation to the PDA, we missed the ostium of the PDA. So it was looking 50% stenosis following the stent implantation. We missed the PDA. We thought that probably we would leave that particular area for medical management. However, when we did the LCBI, we found out that at the ostium of the PDA, the lipid lipid pool was quite good, quite high. It was 529, so we decided that we'll deploy another small stent at the ostium of the PDA, and then we got away with that. That's my last set of slides. Sir, can I take one more minute? Just one more minute. So you could also decide on the balloon-based strategy while doing calcified lesion interventions. This was a patient who presented with effort angina. You could see that he's got a very critical calcified stenosis in the proximal left-handed descending artery. Rotor was a little bit difficult, 1.5 millimeter burr, and there was slow flow inside the vessel following the rotor ablation. We evaluated that particular vessel. It was very interesting. You could see that there is 360-degree arc of calcification. However, at that particular area of calcification, you could see that there is a huge amount of lipid pool, which makes us understand that you needn't be very aggressive at that particular area. If you're very aggressive with post-dilatation, you're likely to distally embolize. Second thing is, when you have huge amount of lipid, probably the calcium, it's not a very thick calcium. You don't have to be very aggressive while doing the pre-dilatation and post-dilatation. We went ahead with the non-compliant balloon dilatation, stent implantation was done. We didn't have to go at very high pressures, and that was the final results that we could achieve. So dear friends, in closing, NIRS IVUS system, it identifies the vessel structure and plaque composition. The IVUS identifies the vessel structure, the plaque composition is identified by NIRS technology, which helps us to identify the high-risk patients, the vulnerable lesions, so that we can modify management plans so that the long-term outcomes are going to be good for these patients. Thank you so much for your patience.